We'll be ready in just a minute. We're getting some slides into a slide cassette for our next speaker. Get cassette ready, then we'll be ready to go. This is our last lecture before we take a break, so I'd appreciate if you'd stick around until after this lecture, and then we'll take our scheduled break and have a couple more lectures after that. Stephen Typaldas earned his DO degree from the University of Health Sciences College of Osteopathic Medicine in Kansas City. He served a rotating internship at Parkview Osteopathic Hospital in Toledo, Ohio, and a family practice residency at Mercy Hospital in Toledo. Dr. Typaldas is board certified by the American Board of Family Practice, and he's currently in practice in Brewer, Maine at the Osteopathic Extremity Clinic, and he's author of the textbook Orthopathic Medicine, Unification of Orthopedics with Osteopathy Through the Fascial Distortion Model. Dr. Typaldas' topic this morning is going to be manipulative treatment of repetitive use injury, repetitive injury of the shoulder. Dr. Typaldas.
I'd like to make sure that everybody gets a handout because I'd like you to follow the handout with the lecture. So I'm going to wait just a minute to let that go out. Okay, here's a gentleman with a repetitive use injury of the shoulder. From this slide, this will tell us a lot of information. Because with people with injuries, we can look at this body language. And from this body language, we know many, many things. What's wrong with this person, how to treat this person, anatomically, what is a pathology, what will feel better, what will feel worse, what osteopathic treatments will make this better, what osteopathic treatments will make this worse. There are many different body languages. I'm going to share some of them with you briefly. This is one I want to spend a little bit of time with you with on a repetitive injury. In the shoulder, when you see this motion, this means something. That's different than this. That's different than this. That's different than this. That's different than this. All of these body languages mean anatomy. It tells what is wrong with this person. In this gentleman's case, he does this. When you see this in your office, when you ask him, where does your shoulder hurt? And he does this. That means one word, and that word is folding. This is a folding distortion of the shoulder. If you have a patient that comes in and their knee hurts, and you say, where does your knee hurt? And they do this. That means one word. And that one word is folding. If they have an ankle sprain, and you say, where does it hurt? They do this. That means folding. So folding distortions always give this body language, wherever in the body that it is, as opposed to this body language. In the knee, it's this. In the sprained ankle, it's this. That means trigger band. In the shoulder, if it's this trigger band, it's this. Or the one we're going to talk about, the STAR trigger band, it's this. So when somebody comes into your office and they say, my shoulder hurts, and you say, where does it hurt? And they say this, you should think STAR trigger band. When they do this, you should think folding distortion. Now this gentleman here, we know from his body language how he got hurt. He got hurt with a motion like this, where there was a traction on the arm. We know that because of this body language. And we know what treatments are going to make it better to fix it, and we know what treatments are going to make it worse. Here's another body language. This is the most common body language you're going to see of a sore shoulder in your office. You notice they don't even touch the shoulder, but they call it shoulder pain. They reach back. They bring their hand up like this. It's a star trigger band. And this gentleman, all of these patients say the same words. Say, where does your shoulder hurt? They grab their shoulder like this, and they use these words every time. It hurts or aches deep in the joint. And the knee, when they do this, hurts or aches deep in the joint. Sprained ankle, hurts or aches deep in the joint. Their verbal description of pain and body language tells you that's a folding. On our next patient, this body language, they never say hurts deep in the joint. They say it's a burning or pulling pain. Burning or pulling. So the verbal description of pain and the body language, the mechanism of injury, the anatomy and pathology, and the appropriate treatment should fit like a glove. Here's the body language again of the star. Gotcha. On your handout, I'd like you to look at this picture. Does everybody have a handout where they can see this? These are the body languages of sore shoulders. This is what people do in your office when they're sitting in your waiting room or they come into your exam room. Watch what they're doing. All of these mean something anatomical. They direct your treatment. They tell you what treatments will work and what treatments will fail. On these handouts you have, there's a number of these. I'm going to focus on only two of these. This one, which is the star trigger band, and this one, which is a folding distortion. You'll see the other ones too, but I just want to talk about two of them. The way that all this is coordinated together with pathology, body language, mechanism of injury, verbal description of pain, and treatments that are anatomically directed to correct that particular distortion is what we call orthopathic medicine. And orthopathic medicine, what it does is it gives us an explanation to the clinical presentation of the body language, and it directs our treatment to correct that pathology. You can use osteopathic techniques. You can use surgical techniques. To make it orthopathic, it has to examine and look at the body from a particular way, which is through the fascial distortion model. So what is orthopathic medicine? It's a clinical utilization of the fascial distortion model within the practice of medicine and surgery. The other word is orthopathy, and sometimes these two words are used interchangeably. They're not exactly the same. In orthopathy, it's the combination of the two words orthopedics and osteopathy, and it refers to the manipulative practice of orthopathic medicine. In other words, examining every injury through the fascial distortion model with your intent of treatment to correct those fascial distortions. So when you look at somebody and they come in and they do this, and you say that's a folding distortion, you're practicing orthopathic medicine. When you do a manipulative treatment to correct that, you're practicing orthopathy. So what is a fascial distortion model? It's a diagnostic perspective in which virtually every injury you're going to see, from fractures to sprain to frozen shoulders, is going to be examined through this model and interpreted as being a type of fascial distortion. There are 6 fascial distortions. Trigger bands are probably the one that many of you may be familiar with. It's a distorted fascial band. That's this one. When you see this body language, that always means trigger band. So if it's there, or if it's here, or if it's here, that means trigger band. And I'll show you in a few minutes why they do that body language. It isn't just happen chance. They do that for an anatomical reason. So if you see somebody doing that in the United States, or in Japan, or in Europe, or around the world, that always means trigger band. The second distortion is a herniated trigger point, protrusion of tissue through a fascial plane. That's this body language. Anybody see this in their office? That's a herniated trigger point. Continuum distortions. It's an alteration in the transition zone between bone and ligament. They point with one finger, usually this finger, and a sprained ankle. Where does it hurt? Here. Tennis elbow. Where does it hurt? Here. In the shoulder. Where does it hurt? Here. The continuum distortion, they always point with one finger for very anatomical reasons. A folding distortion, which we're going to talk about. It's a three-dimensional alteration of the fascial plane. They loosely grasp or cup the joint. A cylinder distortion. It's a tangling of the superficial coils of the fascia. They do this, repetitively squeeze. So somebody comes in, my shoulder hurts. They do this, you think, cylinder distortion. They don't touch their shoulder. It's that tangling of those coils, like a tangled slinky. And a tectonic fixation. It's an alteration in the ability of the fascial surfaces to glide. They're stuck. Try to bring that shoulder up, goes forward. That joint cannot slide. But the two that we're going to talk about are trigger band and folding distortion. So, orthopathically, repetitive use injuries are a little bit different than you might have looked at from a different perspective. Orthopathically, there are two kinds of repetitive use injuries. One is there an accumulation of specific motions that progressively, physically distort the fascia. These are called cumulative repetitive use injuries. These people have a prodrome. In the star trigger band, they say, oh, it's getting worse and worse. It didn't used to be this bad, but the more work I do, the worse it gets. It used to be just down here. Now it's all the way up like this. Clinically, if you see these people as they progress, the first time you see them, they might make a little sweepy motion like this. As the months pass, they make a sweepy motion like this. In the anterior shoulder trigger band pathway, you may see them like this. As that gets worse, you see them with this body motion. That body motion extends for anatomical reasons, which I'll show you. But those people that have a prodrome, where it's an accumulation of repetitive motions and make it worse and worse, those are called cumulative repetitive use injuries. The example I'm going to show you is a star trigger band. The second kind is called a probability repetitive use injury. In this kind, there's a single event, one errant motion out of thousands or tens of thousands of motions, and then boom, they're injured. You may have somebody that makes toothpicks, like I see in Maine, and they do this tens of thousands of times. It never hurts. It never bothers them. They have no pain. They have no problem. They do it one time, oh, now their shoulder is injured. It didn't hurt 1 minute before. It didn't hurt 1 month before. It hurt at that second of injury. That's called a probability repetitive use injury. It's different than a cumulative, and it's different clinically on how you're going to treat them, who goes back to work, and who's going to need maintenance therapy. And in a cumulative repetitive use injury, you can think of it as 1 plus 1 plus 1 plus 1 plus 1 equals n. Small tear plus small tear plus small tear plus small tear. Now you've got an injury. You have this long prodrome of getting worse and worse, and now they can't work. And a probability, it's like spinning a slot machine. Their chances of getting hurt are only a matter of probability. So if they work for 5 years and they never get injured, and all of a sudden he moves that arm when he's making that toothpick, and now his shoulder hurts, and you fix him, he goes back to work. His chance of getting injured is roughly 1 in whatever it was before, 1 in 5 years, 1 in 50,000 times, 1 in 5 million times, whatever it was before. So a probability injury, you don't have to baby that. You don't even have to take him off work. You send him back to work. Fix it, send him back to work. If you can't fix it, still send them back to work. The other kind of injury, you may need to take them off work, or they may need maintenance therapy. The two we're going to talk about are the star trigger band, which is a cumulative repetitive use injury, and a fold and distortion of the shoulder joint. Again, here's that body language. See that? That's folding. The star trigger band, the sweeping motion. Sweeping motion with the fingers is always a trigger band. Clasping over the joint is always a folding. In a cumulative, the anatomical injury increases with repetition of the activity. The more you do it, the more it's going to hurt anatomically and pathologically, the bigger the distortion. Star trigger band. Here's the body language. This is a dental hygienist. I like to think of them as a type specimen for the star trigger band because they get this. How many of the dental hygienists get this? All of the dental hygienists get this. They all do. How many dental hygienists do you see that are over 50 years of age? None. Because of the star trigger band. This keeps them from working. They all eventually end up with what they call fibromyalgia. This all begins with the star trigger band. So all dental hygienists are young because as they accumulate these uncorrected, they just don't think working is worth it anymore. There's the body language. It starts halfway down on the scapula, halfway between the spinal column and the medial border of the scapula. That's where the star trigger band starting point is. And they make this sweeping motion up to the mastoid. That's what they do. Anybody see this in their office? Every day. You should. This is the most common trigger band in the body, and trigger bands are the most common fascial distortion. If you're not seeing this, I think it's because you haven't looked for it. Here's how they get it. Open wide, and then they have to turn. And when they turn, that causes little tiny tears in the fascial fibers along the star trigger band pathway. So this is in your handout. There's the normal fibers of the star trigger band. I don't have this problem. That's the way mine look. They're all in alignment. They're all together. That's normal. But as she comes here and she twists, every time she does that, she gets a little teeny tiny tear because that one position of twisting goes against these fibers in such a way that they just can't stay together. It's the same way with the Ziploc bag. A Ziploc bag will stay together. You can throw it off the balcony up here. You know, put an orange in it, throw it off the balcony. It won't open. But if you take it and you torque it just right, that bag will open. That's how we open a Ziploc bag. When our dental hygienist is doing this, she's opening those fascial fibers. She's causing those fibers to separate. It's this motion. If she did another motion, she won't get the star trigger band. But it's this motion that causes that. And these fibers tear up and down. Now, if she didn't do that motion to work, she won't get this. But since she does, she'll always get this. So all dental hygienists get this. The same way if you open a Ziploc bag and you do it just the way you're supposed to open it, it will open 100% of the time. If you throw it off the balcony 100 times, it won't open once. With these dental hygienists, they'll get this distortion 100% of the time because of this motion. But as they do this, it starts with a little tear. And they do this hundreds of times during the day, week after week, year after year. And as they do this tear gets bigger and bigger. It's like a Ziploc bag. At first you open maybe just a little tiny bit of it. But as you keep pulling, it opens more and more and more until the bag becomes fully open. Orthopathically, that means that it goes along its entire pathway, from the mastoid to halfway down the scapula. The bag opens all the way. That's why we see this body language. First it's like this. Then it's like this. Because the bag opens all the way. That makes the body language more dramatic because the distortion is more dramatic. Also with the star trigger band, it starts to involve deeper layers. So when you first see them, they'll do this. Later you'll see them, a year later, they'll push on it, push hard on it. They're getting to those deeper layers. In the anterior shoulder pathway, they'll do this at first. Later, they'll push hard on that to get to those deeper layers. So you'll see an increase in the distance and an increase in the amount of force that they use to show that body language. This is anatomically why. To treat this, we're going to zip up that Ziploc bag. We're going to force these fibers back together. We're going to take our thumb and we're going to go along this entire pathway, just like we would a Ziploc bag. Force those fibers back together. The deeper this is, the more force you have to use. Patients love this treatment. It hurts, but they love it. Yes? You cannot do this over clothing. You must do this directly on the skin, because you need to change anatomical distortion underneath the skin.
It's very deep. Is there something, can you use one of those massage kind of things to get it deeper, or is it better to just...
It's better to use your thumb. You can use an instrument, but you have to be able to follow this twist and re-zip that bag. So you won't, when you do this, you're going to say, I don't know if I'm on the pathway. How do I know? You may not know because it takes a while to be able to feel what that twist feels like. But your patient will say, you are on it or you are off it. She may have never had this treatment before, but she knows because she can feel this. She can feel that twist all the way up as you re-zip that bag. There will be no doubt in her mind. You may doubt, but there'll be no doubt in her mind. You can do this treatment sitting. You could do it face down. It's your preference. It doesn't matter even how you do it. This is an orthopathic treatment. If you envision this as a trigger band, a fascial distortion, that makes it orthopathic. Let's see here. Here's the treatment. Lots of force. This is the starting point of trigger band technique of the star trigger band. Halfway between the spine and the medial border of the scapula. Lots of force. Use your thumb. You cannot use your finger. It won't be strong enough. You're going to drag that thumb all the way along the pathway of the star trigger band, which goes to the mastoid. Up we go. There should be a red streak. You're going to use more force than you think is necessary. Way more force. You cannot use enough force. You're not going to hurt them. They love this treatment if they have the star. Now, that's a cumulative injury. It gets worse each time they do the injury. Each time they do that offensive motion, that distortion anatomically increases. And a probability, it's caused from a singular event. So probability, repetitive use injuries don't happen like that. They're fine. All of a sudden, boom, their shoulder hurts. This injury occurs from one specific incident out of thousands or tens of thousands of activities. They're not doing this over and over again. They may be doing something else. There's no injury. Then boom, one of those motions causes an injury. What's this body language for? Folding. All these people that you see in my slides here or anywhere else I lecture, they're all real. There's nobody staged here. These are all real people. This is his real problem. This is his real body language. And how does he describe this pain? Aches deep in the joint. They all say this. The motion, the body language, the mechanism of injury should fit like a glove. And this is in your handout. And this is how he got injured. He's a postal worker. And he reaches into that mailbox hundreds of times every day. His shoulder never hurt. He says, I've never had a bad shoulder before. I've done this for 15 years. I've never had a problem. And one day he reached into that mailbox, and when he brought his shoulder back into the truck, oh, it hurt. Where did it hurt? Deep in the joint. The reason that happened is the fascia of the joint capsule and around the joint capsule unfolds and refolds. It's not like a trigger band. It's a different type of fascia. So when he reaches in, the arm gets longer. The way that the arm gets longer is that fascia unfolds. Then when you bring it back, it refolds. In his case, he reached in, turned the arm, came out, and it didn't refold properly. It refolded contorted. So instead of coming back and looking like this, came out, twisted, and refolded, and couldn't refold all the way. The best orthopedic example of this is a dislocation. So if you have a dislocation that comes in your office, the arm is longer. If you measure them, it's longer because the tissue unfolded, it twisted, and it couldn't go back into the socket. That's a unfolding distortion. And the best example orthopedically, again, is a dislocation. If you look at these people, how do they walk in? Like this. Where do they say it hurts? Deep in the joint. What makes it feel better? To pull on it. Have you ever taken a dislocation and pushed on it? That hurts. They won't let you do that. The reason is because this is contorted. When you push on that, that contorts it more. How do we treat a dislocation? Traction, untorque it, bring it back. The same way with this folding distortion. A dislocation is a folding distortion. In his case, he has it's not a dislocation, but it's still a folding distortion. So the treatment will be the same. If he sits in your waiting room, he'll do this. He does that because it unfolds it. It makes it feel better, and it might refold less contorted. He doesn't do this. They don't do that. That hurts. They do this. They put their arm on there. They may push a little bit. That unfolds it. That makes it feel better. It anatomically makes a very slight correction. That's why they do that. The treatment of this, we have to unfold that fascia in the exact direction in which it was injured. Since he reached into the mailbox, it unfolded in this direction. We have to unfold it in this direction. Pull it this way, untorque it, and then let it refold uncontorted. After that, he's fine. This guy can go back to work. You send him back to work immediately. When will he get injured again? The next time, out of some 10,000 or 100,000 times, he does it just wrong. What if we don't fix this? When we send him back to work? Is that going to make it worse? No. Is it going to make it better? It's likely to make it better. Because look at the motion. The only way he's ever going to reproduce that motion is to go back to work and do the exact same thing. So if you can't fix him, don't take him off work. Send him back to work. That's his only chance of getting better. Because when he reaches in that mailbox, he might do it just right and unfold it, and it'll come back. He'll say, I'm fine. This person, you don't take off work. You send him back to work. Working will make him better. The other patient, working will make them worse. So this has ramifications for workers' comp. This person, do not take him off work. Even if you don't know how to fix them, don't take him off work, because working is their only chance of getting better. If you take him off work and you don't fix them, you have taken this gentleman here and given him a lifetime of pain. That will never get better on its own. Now, let me ask you a question. If somebody is a bowler and they get a folding distortion, that's a probability injury. It happens 1 out of 10,000 times. Let's say they throw that bowling ball. So the fascia came and unfolded, torqued. Now it can't refold properly. What would be the best thing for them to do? What's that? Go bowling. The best thing for them to do is to go bowling. Don't tell them to stop bowling. Send them back to bowling. That's what's going to fix them. Now, in your office, how would you fix that, knowing this?
Well, I was just actually thinking that I do a lot of that. People with shoulder problems,
Yeah.
they never heard this before, but I just kind of, like, because I work with fascia,
Uh-huh.
I just kind of intuitively had done this.
Well, this only works for foldings. It does not work for trigger bands or any of the other 4 distortions. So sometimes people will say, gee, I do this and it works. With the folding distortion, it should work every time. But if you do this on a trigger band or something else, it might make it worse. It'll only make a folding better. So if we have a bowler and they do this, this is the direction we want to use for this injury. What direction will we use for a bowler? Down. We want to treat him like this. So you may have to get up on have him stand on the table, pull it down this way. You want to go through that exact motion to cause the pain. The way that he was injured, that's how you fix it. Take him through that motion again. The same way here. We put him in this direction. We unfold it in the direction of injury. Now, if we were to take this arm here and push on it in this direction, that'll cause maximum pain. So if we take the arm and bring it up here and push, that'll cause some pain. If we bring it down here and push, that'll cause some pain. But if we bring it in this direction and we push, that's going to cause some pain. That's going to cause maximum pain. Now, there are two subtypes of folding distortions. This is an unfolding. There's also a refolding. In a refolding, the fascia becomes compressed. And in that case, the treatment is to compress it. So in an unfolding, traction feels better. Compression feels worse. In a refolding, compression feels better, and traction makes it worse. But for this lecture, we're just talking about unfolding distortions. And this is a probability injury. It happens one single errant motion out of thousands or tens of thousands of times. Here's the treatment. In the same direction in which he was injured. If he was a bowler, I'd take him in this direction. If he was walking down a trail and he slipped and grabbed the branch, I'd treat him in this direction. Now, when we see this gentleman coming in, we can tell how he got injured. We know what's wrong with him. He did this. So we think folding. We can put his arm through the motion. When we bring it to here, he says, that feels good. We know he was injured in this direction. If we push on it, he says, oh, that makes it hurt. We know that that's the proper direction of treatment. We know that's the proper direction that he was injured. This model tells us that. How they're injured, mechanism of injury, body language, treatment. They should all fit like a glove. When we pull on this, you want to do traction, untorque it, and a thrust. And it'll make a big pop when you do it properly. That pop is the fascial capsule unfolding. And then they feel a world of a lot better. Oh, they should be cured. So cumulative versus probability, repetitive use injuries. What does this mean clinically? And this is in your handout. So again, here's the trigger band. Sweeping motion of the fingers in a linear pathway. Trigger bands are always linear, along a line. This is it. This is what they do. As opposed to a folding, they do this. Different body language. Verbal description of pain. Trigger band, a burning or a tight or a pulling pain. A folding, aches deep in the joint. They all say that 100% of the time. The trigger band is going to be cumulative. The fibers tear more each time they do that activity. With the folding, it's probability. It doesn't hurt until boom. They may go their whole life and never have an injury. As opposed to a dental hygienist, all of them get the star trigger band. Every dental hygienist gets a star trigger band. They have to. If you open a Ziploc bag the way that it's supposed to be open, every Ziploc bag will open. There will be no exceptions. So with a dental hygienist, every dental hygienist gets the star trigger band. With a folding distortion of the shoulder, not every mail carrier gets that. It depends exactly on that one errant motion, one of tens of thousands. Now, let's see here. With the star trigger band, the more times it's repeated, the more anatomical the injury. The more anatomical the injury, the more symptomatic they become. So they progress in their symptoms, and they progress in their body language, and eventually they can't work at all. With the folding distortion, once injured, repeating the injurious motion may correct the anatomical distortion. So with the star trigger band, these people, you may have to even take off work until you can get that fixed. But with the folding, don't take them off work. Send them back to work. That's their best chance of getting well. And as they do that injurious motion at work, they get better and better. Because it unfolds a little bit, it refolds a little bit, unfolds a little bit, refolds a little bit. So they're just the opposite. The more they do the injurious motion with the star, the worse they get. With the folding, the more they do it, the better they get. On the star trigger band, once the anatomical correction is made, if you continue the offending activity, the anatomical injury will reoccur. So if you take a dental hygienist and you fix her and you send her back to work, she's going to get the star trigger band. If you re-zip a Ziploc bag and then you start to unzip it, it's going to unzip 100% of the time. You send these people back to work, they're going to get the star trigger band. With the folding distortion, once the anatomical injury is corrected, the chance of re-injury is exactly the same as it was before they got injured. So if they've been working 5 years and they never had this, likely they'll work another 5 years before they get injured again. You don't have to have any kind of therapy or maintenance. They're fixed until they get injured again. The treatment of the star trigger band, it's physically, you reapproximate the fibers with force from your thumb. That's called trigger band technique. That is the object of trigger band technique, is to force those fibers to reapproximate, to re-zip the Ziploc bag. With the folding distortion, you have to physically traction the arm in the same direction in which the injury occurred. Now, if you use trigger band technique on a folding distortion, will it work? No. Will it make them better? No. It'll have no effect. You have to match the anatomical injury with the treatment. Now, you may give an osteopathic treatment of a star trigger band. All I ask of you is that you think about orthopathically what that osteopathic treatment is going to do to those fibers. So you'll have some osteopathic treatments that may help reapproximate those fibers. You may have some that will not do that. With a star trigger band, you may consider temporarily stopping the work that they're doing. Whatever that motion is, you may want to stop that until you can get that problem fixed. I don't recommend you do that, but you may want to. With the folding distortion, don't rest that injury. If you do, you're committing this person to a lifetime of pain because you're not going to fix it. If you can't fix it and you take him off work, likely the only thing that's going to fix that is for him to go to work. The same with the bowler. If they get a folding of the shoulder from bowling and you say, don't do any more bowling, they're going to have a lifetime of pain because folding distortions, if they're not corrected, hurt forever. With the star trigger band, if the patient resumes work and continues exposure to the offending activity, they will require maintenance therapy because every time they do that twist, that fiber is going to tear. So you may ask them to come to your office once a month, once every 2 weeks, once every couple months. You decide. They'll need to be seen if they want to continue to work. What happens to these people is they work and work for years in pain, gets worse and worse, and finally they say, I can't be a dental hygienist anymore. I quit. I have to do something else. They don't have to do that either. You can treat them on a maintenance type of therapy and keep them working well into their 50s or 60s or 70s. With the folding distortion, if the patient resumes the same work and continues the offending activity, no maintenance therapy is necessary. You can kick them out of your practice. They come in, you do the treatment, send them back to work. You don't need to see them again. So I'll see you in 5 years when you're hurt again. Questions? Yes, ma'am.
The fibers along that star trigger band are not just longitudinal, there's lots of fibers along the why is just that one motion sufficient?
Well, the fibers that tear. Oh, the question is, there are other fibers that may pass over the star trigger band pathway. And she's wondering, why is it that we don't really have to pay attention to those? Is that correct? And yeah, but they don't tear. Because of this motion, only these fibers tear. And I'm going to answer another question before somebody asks it, okay? And that's what happens if you treat a fascial band with trigger band technique that doesn't have a trigger band. That's just like re-zipping a Ziploc bag. If it's already zipped up, re-zipping it won't make a difference. It won't cause an injury.
You say you send these people back to work. I have a hard time getting people back to work when they're in severe pain.
They won't be in pain. You fix that folding, they don't hurt anymore. They're fine. There's no injury. And they'll go back to work anyway, if you tell them to.
You said, say you couldn't get it fixed, send them back to work, it can work itself out.
Yeah, on a folding, yes.
Correct.
Yes.
Get them to go back to work.
You tell them you go back to work. This will help.
Does the use of muscle relaxers affect
No.
the body's ability to heal this?
No. I suggest you don't do that. That will give credit to the muscle relaxer that you deserve. Yes? Well, the reason is because the fascia itself is protected in many, many different directions. But to give you mobility, it can't protect in every direction under every circumstance. So it's going to have some weaknesses in very specific directions where it can tear. The same way with the trigger band sprained ankle. Trigger band sprained ankle, they go like this. That's the only way you get a trigger band sprained ankle. That has the body language like this. Well, that ankle can be protected in many, many different planes, but it can't be protected in this direction. So there are going to be some areas where the fibers just can't tolerate any kind of excessive force, and they'll tear. Yes?
What fibers that you say that you're reapproximating?
These are the fascial fibers of the band, the fascial band. In some other areas, it could be ligament or tendon or retinaculum. In this case, these are just fascial fibers.
And so if you are reapproximating them, how are they healing the trigger band effect?
How are they healing? They are healing because once they are reapproximated, they anatomically seal the same way a Ziploc bag does. Once you zip that bag up, it's sealed and it stays together. Same way with these fibers until they get pulled apart again. Yes?
What do you do with some of the folding injury? It comes to you 5 years after they've done all of the things that they were supposed to do.
Okay. The question is, what do you do with the folding distortion that comes to you 5 years later? The bad thing about this is that fascial distortions begat fascial distortions. So if you don't correct that folding, it will create other fascial distortions. You have to correct everything else first, and then go and do the folding distortion, which would mean trigger bands right off the bat. Yes? No, it's straight along. It's just like a Ziploc bag, a linear pathway. Yes, sir?
What about after the start of your treatment, going back and getting the reevaluation of ergonomics?
That would be a good idea. And I'd be most anxious to tell my dental hygienists what they could do so they don't get this.
Let me just make a quick announcement.
Sure.
For those of you who wish to continue asking questions or talking to Dr. Tapaldos, you can do that. We're going to take a quick break. There's additional handouts to Dr. Tapaldos over on the water table, as well as some brochures regarding his book. And we're going to meet back at 10:30 to continue the lectures. Anybody that wants to continue asking questions is